It's fine. Okay, so here you see a trap gun injury, which is made for wild animals. So, although it is made for wild animals, accidental injuries to people are very common. When you step on the trap, the gun goes off. And this is a person who has injured his leg due to a trap gun. And this is his X-ray. You can see both the bones of the leg are broken. So that's why you have to learn about the anatomy to treat such patients. Okay. So the lecture today is on the leg. Sorry. The objectives are to describe the general layout of the region, describe the attachments, actions, innervations of the muscles, describe the nerves and blood vessels of the region, and explain the anatomical basis of common clinical conditions in the leg region. So these objectives have to be covered through the lecture, the practicals, the dissection sessions, and through self-studying. You have to read up on this area. When considering the osteology, you have already covered the osteology of the lower limb, I suppose. So mainly there are two bones involved in the leg. They are the tibia and the fibula. Now the lower limb is comparable to the upper limb in many ways. So if you remember the forearm, there also you had two bones, the ulna and the radius. So similarly, in the leg, you have two bones, but here one bone is larger than the other. The tibia is larger than the other, the fibula. And in the tibia, you have the two condyles, the lateral and the medial condyles, the shaft, and in the distal limb, you have the medial malleolus. And in the fibula, you have a head, the head, the neck, the shaft, and at the lower limb, you have the lateral malleolus. So, just briefly look at the joints related to the leg. You will have a separate lecture on the joints, so I will not go into too much detail. So, the knee joint is made up of the femur, the tibia, and the patella here. You have the medial and the lateral condyles of the femur. They join with the medial and the lateral condyles of the tibia, and the joint there forms a synovial joint, and it's a modified hinge joint. It's called a modified hinge joint because in addition to flexion and extension, there is a bit of rotation occurring there. Then you have the joint between the femur and the patella. It is also a synovial joint, and it's a plain gliding joint. Then you have the proximal tibiofibular joint between the fibular head and the lateral condyle of the tibia. This is also a synovial joint. There's a synovial cavity here, and it's a plain gliding joint. There's a bit of rotation, but not much of movement occurring there. Then you have the distal tibiofibular joint at the distal end of the tibia and the fibula. And here you have a syndesmosis or a fibrous joint. These two bones are joined by a ligament. Then at the most distal end, you have the ankle joint, where the tibia and the fibula articulates with the talus, which is a bone of the foot. This is the talus. So they form a covering around this talus. You have the lateral malleolus from the fibula, and the medial malleolus from the tibia and the distal end of the tibia. So this is also a synovial joint, and it is a hinge joint. So flexion and extension is possible here. So usually extension means dorsiflexion. So when you have the foot like this, moving the foot away from the floor, it's called dorsiflexion. And it's considered as the extension at the ankle joint. And flexion, like standing on your toes, it's called plantar flexion. Okay, so similar to the upper limb, you have compartments. And so in the forearm also you had compartments surrounded by the deep fascia, the interosseous membrane, and intermuscular septate. So here also you have the same thing. So this is the tibia, and the deep fascia is attached to the tibia at this area, the anteromedial area, and it surrounds all the contents of the leg, right, like this. Then you have the interosseous membrane here, and it separates the anterior and the posterior compartments. Then you have the intermuscular septate from the deep fascia to the fibula. Then you also have a deep transverse fascia separating the posterior compartment into two compartments, the deep compartment and the superficial compartment. So each of these compartments have their own muscles, nerves, and blood vessels, the veins and the arteries. So in this diagram, you can see them separately. So here you have the anterior compartment, the lateral compartment, the deep compartment of the posterior group, and the superficial compartment of the posterior group. So if you remember the lecture on the forearm, you will remember about the compartment syndrome. So again, similar to that, compartment syndrome can occur in the leg as well. So these compartments are closed off, right? They are tightly closed spaces. Therefore, when there is soft tissue injury due to blunt trauma, like if you get hit by a pole or something, or if there's a fracture of the bone, this soft tissue, these muscles will get damaged, and it will result in swelling of these muscles and the soft tissue surrounding. That will first lead to compression of veins because the walls of the veins are thin, right? It will cause impaired blood flow and cause further swelling in these areas, and it will cause ultimately it will cause compression of the arteries and loss of blood supply to these muscles and ischemia, that is, the cells will die off. And if it's not treated within 4 hours, it will not be reversible. The damage will be permanent. So it's treated by opening these compartments. So here the compartments are open by a scalpel. So you have to cut open the skin, the subcutaneous tissue, and the deep fascia to open up these spaces. So if it's not treated within 4 hours, if it's not detected and treated within 4 hours, you will not be able to reverse the damage. So if you look at the muscles of the compartments, in the anterior compartment, you have 4 muscles. You have the tibialis anterior, the extensor digitorum longus, and the fibularis tertius. And here you have the extensor hallucis longus. So all these arise from the anterior aspect of the tibia and the fibula. These are, if you try to understand what their meaning is, it will be easier for you to remember. So it's in the rising from the tibia, from the anterior aspect. It's called the tibialis anterior. And then you have the extensor digitorum longus. Extensor means extending the digits. So this extensor digitorum is attached to the extensor expansion of the lateral four toes. So that's why it's called the extensor digitorum. Longus means it's long. There's a extensor digitorum brevis in the foot area. So brevis means short, because there's a short extensor of the toes. The longer muscle is called longus. Then hallucis means the big toe. Extensor of the big toe is called the extensor hallucis longus. Then you have the fibularis tertius. When you look at the lateral compartment, there are two fibularis or two peroneal muscles. So this one is the third peroneal muscle. Therefore, it's called the third fibular muscle, fibularis tertius. So peroneus and fibularis means the same. So you can use those two, any of these two words. Then here you can see the lateral compartment. Here you have two muscles, the fibularis longus and the fibularis brevis. The fibularis brevis is attached to the base of the fifth metatarsal here, and the fibularis longus extends over the plantar surface of the foot, and it gets inserted into the medial aspect of the foot, to the medial cuneiform at the base of the first metatarsal. And when you look at the posterior compartment, you have two groups, the superficial and the deep. In the superficial compartment, you have three muscles. The gastrocnemius, this is the gastrocnemius. So you have two heads, both arising from the two condyles of the femur. And they fuse with the tendon of the soleus here, which is a muscle situated more deeper to the gastrocnemius, and they form the calcaneal tendon, also called the Achilles tendon. So Achilles was a Greek warrior. I don't know if you know about these stories, but Achilles, when he was a baby, he was dipped in a river called Styx. So this river is the boundary between earth and the underworld. And when he was dipped, he was held on by his heel. So when his mother dipped him into the sea, dipped into this river, he was held on by this heel. And when you bathe in this river, you become invulnerable to damage. Your skin can resist any harm. It cannot be damaged by anything. So in Achilles, only the heel could be damaged, and any other area of his skin couldn't be damaged. And ultimately, during the Trojan War, he was arrow was hit into this area to the heel, and that's how he was killed. So that's how this Achilles words comes in here. So this is the Achilles tendon. Then you have another small muscle here, the soleus, which also rises from the lateral condyle of the femur. Then you have the deep groove. Here you have 4 muscles. The popliteus, it's found in the superior area. It arises from the lateral aspect of the femur and gets inserted to the medial aspect of the tibia here. Then you have 3 muscles: flexor digitorum longus, flexor hallucis longus, and tibialis posterior. So this muscle correspond to the muscles of the anterior compartment. You have a flexor of the digits, long flexor of the big toe, and the tibialis posterior, which plantar flexors the ankle joint. So it arises from the tibia, from the posterior aspect. So therefore, it's called the tibialis posterior. Then you have a special region in this area behind the knee called the popliteal fossa. So this is the popliteal fossa. When you look from the posterior aspect, you can see it is diamond shaped, and the boundaries are formed by the semitendinosus and the semimembranosus muscles in the upper medial aspect. In the upper lateral aspect, you have the biceps femoris, biceps muscle, and then inferiorly you have the 2 heads of the gastrocnemius, the medial head and the lateral head. And on the lateral aspect, you also have the plantaris muscle here. And then if you look at the contents, you have more deeply, you have the popliteal artery. And then as you come superficially, you have the popliteal vein and the tibial nerve. Then, so the sciatic nerve divides into its 2 components in the lower third of the femur. So one component is the tibial nerve, other is the common peroneal or the common fibular nerve, and it travels along this medial border of the biceps. Okay. So this is also a content. Then you have the posterior cutaneous nerve of the thigh, which arises from the sacral plexus, and the small saphenous vein, which is a branch of the tibial vein and drains the superficial structures of the posterior aspect of the leg. Also, you have lymphatic nodes situated in this area, and other small nerves related to the knee joint, like the genicular nerve. Genicular branch of the obturator nerve, other connective tissue, and those things. Now, this is a clinical point you have to know about the Baker's cyst. It's a swelling seen at the posterior aspect of the knee. It occurs in conditions like osteoarthritis and meniscal tear. So you know the menisci are found in the knee joint. So if it's damaged or during osteoarthritis, this will also cause damage to the cartilage and the bone. Then there will be excess production of synovial fluid. And when you bend the knee, when the knee is flexed, this fluid will escape through the posterior aspect of the knee joint and get accumulated. And when you extend, it will get trapped here. So the fluid will get accumulated and form a painful cyst, a painful swelling at the back of the knee joint. So to treat this, only draining this cyst will not be enough, because even if you drain it, fluid will again get collected in this area. So you have to gain access into the knee joint by a method called arthroscopy. and you have to treat the cause. Treat the osteoarthritis or the meniscal tears. So this is a picture of the Baker cyst. So you have a small activity to do at home. You can mention the muscles, the blood vessels, and the nerves of each of the compartments. Okay. And take each muscle, mention their compartment, their proximal and distal attachments, the nerve supply, the nerve roots, and the actions. You can work out the action from their attachments. Right? So when you talk about the arterial supply in the posterior aspect of the lower limb, so in the popliteal region, you have the popliteal artery, which is a continuation of the superficial femoral artery. So at the lower end of the popliteal fossa, at the lower part of the popliteus muscle, it divides into two. You have the anterior tibial and the posterior tibial. Anterior tibial artery is smaller compared to the posterior tibial. So this anterior tibial artery pierces the interosseous membrane and enters the anterior compartment. And it travels on the interosseous membrane between the muscles of the anterior compartment, the extensor digitorum and the extensor hallucis. Then the posterior tibial, it travels in the posterior compartment and gives off a branch, the peroneal artery or the fibular artery. So both of these arteries travel in the posterior compartment, and usually the posterior tibial artery supplies the muscles of the posterior compartment, and the fibular artery or the peroneal artery, it gives off branches to the lateral compartment where it supplies the muscles of the lateral compartment. So the superficial femoral arises from the adductor hiatus here, and in the popliteal fossa, it's called the popliteal artery. And here at the lower body of the popliteus, it divides into two: the anterior tibial artery and the posterior tibial artery. And here you can see the fibular artery. So the fibular artery travels on the lateral aspect here. And the posterior tibial artery enters the foot here. Yes, and the anterior tibial artery, when it crosses the ankle joint, its name changes into the dorsalis pedis artery. It is the same artery, only the name changes here. So it's important to know about the pulses. How and where to palpate for the pulses. Here, the popliteal pulse is shown. You have to, the artery, if you remember, is situated deeper to all the other structures, the vein and the nerve. So you have to palpate a bit deep and press the artery against the tibia. Then you can feel the pulse. Then you have the posterior tibial artery. This crosses the ankle joint posterior to the medial malleolus. There you can feel the posterior tibial pulse. And here you can feel the dorsalis pedis pulse between the tendons of the extensor digitorum and the extensor hallucis, as I remember. So you have to know how and where to palpate these pulses, because there can these arteries can narrow in a disease called occlusive arterial disease. So narrowing of these arteries will cause impaired blood flow to the muscles, and it will cause pain of the leg muscles. So therefore, you have to know how to palpate these pulses. Then I think you know enough about anastomosis now. So anastomosis are there to ensure blood flow to the distal parts of the body if there is any obstruction in the proximal parts. So in the knee joint also you have an anastomosis. You have anastomosis between the femoral artery, the circumflex femoral, the lateral circumflex femoral, the popliteal, and the anterior tibial artery here. So from the femoral artery, you have the descending genicular artery here. And you also have the superior lateral genicular artery. And then on the medial aspect, you have the superior medial genicular artery. Then from the lateral circumflex femoral, you have a descending branch. Then from the popliteal artery, you have the inferior lateral and medial genicular arteries. Then from the anterior tibial artery, you have the circumflex fibular and the recurrent branch of the recurrent branch from the anterior tibial. Then we have the venous drainage. So similar to the upper limb, you have a set of deep veins or venae committantes which follow the arteries, and they can be dual, 2 veins for each of the arteries. Then more superficially on the subcutaneous tissue, you have superficial veins. In the leg, you have the small saphenous vein on the posterior aspect of the leg, and it travels lateral posterior to the lateral malleolus. And on the medial aspect of the leg, you have the great saphenous vein. So it travels anterior to the medial malleolus here, and it travels in the medial aspect of the leg here. Then you have to know that there are connections between these two groups. These are called perforating veins. These join the superficial veins to the deep veins. It's not shown clearly in this diagram, but there are diagrams in textbooks and you can look at them. So these perforating veins join the superficial veins to the deep veins, and they have valves. And these valves allow blood flow only from the superficial veins to the deep veins. So there are certain areas you have perforating veins, and if these valves are damaged, it will cause backflow of blood to the superficial veins and will cause the superficial veins to enlarge. And this will cause a condition called varicose veins. So you will have to read about varicose veins, and there are different causes. You can read up on them. So then another condition is deep vein thrombosis. So the muscles of the leg, when they contract, they pump the blood in the veins of the leg, the deep veins of the leg, upwards towards the heart, right? Upwards along the limbs towards the heart. So when there's prolonged immobilization, this muscle pump will not work, and that will cause blood to stagnate, blood to stay in the veins, and cause it will, the blood will get together and form clots like this. So here you have clots formed, and these clots can break off, and these clots will travel along the veins and they can enter the heart and the lungs. And then if it blocks the artery supply in the lungs, it will cause that area of the lung to stop working. That area will die off. So that condition is called pulmonary embolism. So that can even lead to death. So it's a very serious condition. So it's important to, like when you are traveling for a long time, it's important to move your legs a bit. Otherwise, this deep vein thrombosis can occur and may cause emboli, which can travel to the heart and the lungs. Then we come to the lymphatic drainage. So, as in the upper limb, the superficial lymphatics follow the superficial veins and the deep lymphatics follow the arteries. When you consider important groups of nodes, you have the popliteal nodes in the popliteal fossa. These drain the lateral aspect of the foot and the leg. Then you have in the inguinal region, you have the superficial and the deep inguinal nodes. Then about the nerve supply. So the skin is supplied by cutaneous nerves. With nerves like this, the saphenous, the sural, and the superficial fibular nerve. Then there are different areas of the skin supplied by different different spinal levels. So you have to know about this to detect any spinal damage. So if there's spinal damage at the L4 level, you won't be able to feel sensations in this area. Like that, for that you have to know about the dermatomes. So you can leisurely study these diagrams. Then the deep nerves. So you have the sciatic nerve. The sciatic nerve, you know, has two components, the tibial and the common peroneal. So in the lower third of the thigh, the femur, it divides into its two components, the tibial nerve and the common peroneal nerve. So the tibial nerve travels in the middle of the popliteal fossa, and the common peroneal travels along the medial border of the biceps muscle. Then this tibial nerve travels along the posterior compartment, and it gives off a branch, the sural nerve, which supplies the which becomes subcutaneous and supplies the skin. Then the common peroneal nerve, this turns around the neck of the fibula. We have the fibula in this region, so it turns around the neck of the fibula, and within the peroneus longus, it divides into two, the deep peroneal and the superficial peroneal. So the superficial peroneal travels in the lateral compartment, and the deep peroneal nerve enters the anterior compartment and travels with the anterior tibial artery. So here you have the sciatic nerve divided into the tibial nerve and the common peroneal nerve. And the tibial nerve gives off the sural nerve here. And the common peroneal nerve, it divides into the superficial peroneal or the superficial fibula, which travels in the lateral compartment of the leg, and the deep peroneal. It travels in the anterior compartment. So here, when it crosses the neck of the fibula, it's subcutaneous. This area can be felt through the skin. The nerve can be felt through the skin. And here it is, because it's closer to the skin, it's susceptible to damage. If there's a trauma, if someone hits you in this area, or if there's a fracture of the neck of the fibula, this nerve will get damaged. And this nerve is responsible for supplying the anterior compartment muscles and the lateral compartment muscles. So the anterior compartment muscles are involved in dorsiflexion of the foot, and the lateral compartment in eversion of the foot. So I hope you know what inversion and eversion are, right? So if this is a foot, so lifting the foot upwards is dorsiflexion. Lifting only this side upwards is called eversion, if this is the lateral aspect. And lifting this side only is called inversion. So I hope you can understand. You can read up and watch videos on this as well. So here, so when this is not possible, when the common peroneal nerve is damaged, dorsiflexion is not possible. And when the person is walking, the foot will drop. So usually when the foot is lifted, there's a bit of dorsiflexion occurring here to keep the foot off the ground. But here, let's see a video. So this leg is affected. The common peroneal nerve is affected, and he has to lift the leg before keeping it. Right. Then another clinical point is the sural nerve biopsy. So the sural nerve travels subcutaneously, it's superficial, and it can be accessed posterior to the lateral malleolus. Oops. In this region. So here you have the small saphenous vein, and here you have the sural nerve. It can be accessed in this area behind the lateral malleolus, and this nerve biopsy is just taking the nerve out for testing. So it can be used for diagnosis of neuropathies, diseases of the nerve. To diagnose diseases of the nerve, this sural nerve can be taken, and also for nerve grafts. If there are damaged nerves elsewhere in the body, you can take a part of this nerve. Here I have mentioned a link for a sural nerve biopsy. You can watch it later. Then another small activity for you. For each of the nerves, you can mention the compartment, the branches, the cutaneous area supplied to them, and the muscles. So in summary, we talked about the osteology and the joints, about the fascial compartments, the muscles, the blood supply, about the lymph drainage, the nerve supply, and some common clinical conditions. Right? So at home, you can read about our limb fractures, about tendocalcaneal rupture, and varicose veins. So these are the references I have used. Okay, thank you. So do you have any questions? There's a question in the chat. What is the difference between pulmonary embolism and varicose veins? In both, blood pools up. Okay, so sorry. Hmm. So pulmonary embolism and varicose veins. So pulmonary embolism, by this, I think you're asking about the deep vein thrombosis, right? So I told you in the limbs, in the leg, you have a set of deep veins. So if this, you have deep veins and superficial veins. So superficial veins are closer to the skin. These are the small saphenous and the greater saphenous veins. And the deep veins follow the arteries, the posterior tibial, anterior tibial, and the peroneal veins. So DVT or deep vein thrombosis occurs when blood is pooled up in these deep veins. Right? So blood gets pooled up and they accumulate here and they can form clots. So usually blood is pumped upwards by the action of muscle contraction. When muscles around these veins contract, it will cause the blood to flow upward. So when that doesn't occur, blood will get pulled up. Not usually in normal healthy people. In these people who are like elderly people, in like there are some conditions, but for you just remember in people who are like elderly, this can occur. So these will form clots. The blood will accumulate together and then pieces of this clot can break off, and so these are not normal blood cells. These are blood cells accumulating together, forming a large clot. So these can travel upwards in these veins, and then they can enter the heart and the lungs. If they enter artery of the lung, it will cause obstruction and impaired blood flow to the lung and will cause a part of the lung to stop working. So that is pulmonary embolism. It occurs in DVT. Varicose veins. So these veins are connected to these deep veins. And at the inguinal region, you have the saphenous opening. There also the great saphenous vein enters the femoral vein. Here also you have valves, and it will cause blood flow from the superficial veins to the deep veins. Right? So when these valves are affected, it will cause blood to flow in the other direction to the superficial veins. Right? So then blood will get collected in the superficial veins and it will get dilated and tortuous like this. I think you all have seen varicose veins, right? So the veins of the lower limbs are dilated like this. This usually does not cause like emboli to enter into the deep system and travel to the lung and the heart. But there is varicose veins also increase the risk of DV, deep vein thrombosis, but not directly. Right? Because of accumulation here, it can cause clots in the deep. If it causes clots in the deep vein, it can lead to deep vein thrombosis and pulmonary embolism. But if you take the two conditions separately, they are different. Right? So varicose vein is accumulation of blood in the superficial veins, and DVT is accumulation of blood in the deep veins. Okay. So. Can you explain about the inversion and so it's inversion and eversion. Okay, I'll tell you. Can you please upload this recording? Okay, I will upload the recording. The most initial part I forgot to explain, but when I started the lecture, I started recording, so I will upload the recording. Yes, we are having the power cuts. It's very troublesome, isn't it? Does DVT affect the form varicose veins? Are you asking whether because of deep vein thrombosis, varicose veins occur? It's not a non-common phenomenon, but I guess it can occur. Can you explain the anterior compartment syndrome? Okay. So, inversion and eversion. How can I? So, if this is the foot and you turn the foot inwards, that's inversion. And you keep the foot here and you turn the foot outwards, that's eversion. Right? So, this is inversion, eversion. Just imagine it in a leg. And there are videos in YouTube as well. You can always see them. Then about the anterior compartment syndrome. So I think you remember about the compartment syndrome in the forearm. I hope you remember. So compartment syndrome is something you have to know about. So when there's damage to so these compartments are closed off spaces. They are sealed off by this deep fascia, the interosseous septum, and the intermuscular septum. Right? So if you take the anterior compartment, you have the deep fascia, the anterior intermuscular septum, the interosseous septum here. So this area is the anterior compartment and it is a closed off space. And if you have blunt trauma, if you hit this area with a pole or something, or if there's fracture of these bones, it may cause damage to structures in this compartment. So then this, when these structures are damaged, it will lead to swelling of these structures, mainly the muscles here, right? So when they expand, when they start to swell, first the veins will get compressed. The veins have very thin walls, right? So first these veins will get compressed. So if you take a compartment, you have the different muscles. And you have the veins and the arteries and the nerves. So these veins will get compressed first, and it will cause impaired blood drainage and will cause blood to get accumulated in these areas and will cause further swelling. And it will cause ischemia, that is impaired blood supply to the nerves, and will cause pain, right? It will damage these nerves and cause pain. And finally, the arteries which have a thicker wall, they will get compressed and cut off the blood supply completely to this compartment. Then these muscles will get damaged. There will be loss of blood supply and the cells will die off, right? So then there will be irreversible damage. The damage will not be able to be repaired, and here you can see it will get necros. That means the cells will die off, right? So when you have this compartment syndrome, what happens first is what you can detect first is pain, right? The patient will have severe pain which is not compatible with the damage. So if the patient is complaining of severe pain, you have to take care and see what's happening with the patient. And like if you stretch these muscles, passively stretch these muscles, it will increase the pain. So at that stage, you have to diagnose and cut this compartment open and relieve the pressure. And if not, if 4 hours pass, the arteries will get closed off and cause permanent damage. Right? I hope you are clear about that. Can blood flow from deep veins to the superficial veins through valves? No. So these are one-way valves. They only allow veins to drain from the superficial area to the deep veins. Only if these valves are damaged, it will cause blood to flow from the deep veins to the superficial veins. Then that will lead to varicose veins. For the veins, do you do the contractions of the muscles outside surrounding the vein allow the blood to be pushed up? Is DVT more likely to happen to those that tend to sleep or sit more? Yes, definitely. So DVT, so in patients who are bedbound, that is, they are very ill and have to stay in the bed like for long times, for weeks to months, they are very prone to DVT. So usually apply bandages or stockings for their legs to prevent DVT. So these stockings will tighten around the leg and cause the blood to flow upwards. So it's also said to occur during when you travel in planes. You have to stay for hours in planes. Then you have to sit for a prolonged time And if you don't move your legs at all, the blood will tend to clot and it will cause DVT or deep vein thrombosis. Okay, so I think I got all the questions. If you don't have any more questions, we can stop the session. Right, okay, thank you.
Thank you.
Thank you, madam.
Thank you, madam.
Thank you, madam.
Thank you, madam.